Good evening, one and all. So, I, Dr. Sciatica Das from the IAP Digital Media team, welcome you all to today's webinar, which is on low back pain and its management by Dr. N Mishra. This webinar is being conducted by IAPWC West Bengal, and today's moderator is Dr. Kuntalika Chakraborty. So, without wasting much time, I would just like to request the moderator of the day, that is Dr. Kuntalika. Please take over and start the webinar with the host introduction. Thank you.
Am I audible?
Dr. Kuntalika, you are not audible. Please unmute yourself.
Hello, I'm audible now?
Yes, yes. Please start.
Okay. Thank you, ma'am. Good evening, everyone. On behalf of IAPWC West Bengal branch, I, Dr. Kuntalika Chakraborty, today's moderator and coordinator of coordinator of North 24 Pargana district, welcome you all for this event. Today's webinar has been organized by IAPWC West Bengal branch on occasion of World Physiotherapy Day 2021. We have got Dr. N Mishra sir, consultant orthopedic trauma and joint replacement surgeon, as resource person for today's topic, that is a low back pain and its management. I welcome our president, Dr. Sanjeev Jha sir, our national head, Dr. Ruchi Varshney ma'am, zonal head, Dr. Rina Srivastava ma'am, and all the organizers and participants. Sir, we are very much grateful that we got the opportunity to have you in this webinar and would further request you to share your valuable inputs in this regards. Thank you, sir.
Hello, I am audible.
Yes, sir.
Should I start?
Yeah, sure, sir.
Today topic is low back pain and its management. I am attached to Kolkata Medical College now. I have done MS from Medical College itself, then DNB from New Delhi. So without wasting much time, I am just concerned with the topic. Now I am starting the topic. Low back pain is the most disabling disease which everyone must have encountered in its life. So definition is any type of physical discomfort which occur anywhere on the spine or the back, ranging from mild to disabling pain. Disabling pain even can so be severe that even the patient cannot get up from the bed.
Sorry to interrupt you. Can you please increase your volume? The voice is very low.
Just wait. Is it okay now? Is it okay now? Is it okay now?
Still low. Can you take the microphone closer to you?
Is it okay now? Just increase the volume.
So you're audible, but your voice is pretty low. Please take the microphone closer to your mouth while you speak.
Okay.
Thank you.
Okay. Now, is it okay? Is it okay now?
It is better. Yes, it is better. Kindly continue.
Okay, okay. So, low back pain is a physical discomfort which can be of any type, which can occur anywhere on the spine or the back, ranging from mild to disabling. Even the disabling feature can be so severe that the patient even cannot get up from the bed. Or on the one fine morning, patient find himself or herself lying on the bed, so that she even cannot stand or turn around. It can be so much disabling. So epidemiology, about 60 to 70% lifetime prevalence, 80 to 90% patients have recurrent episodes. It is the second most common complaint to visit a physician or surgeon. Low back pain is a cause of long-term working disability of the patient. Etiology. It can be of various etiology, like it can be congenital, traumatic, inflammatory, degenerative, neoplastic, metabolic, from the abdominal sources, and some miscellaneous causes are also there. We will deal one by one. Actually, congenital variety of low pain is very much rare, and it is almost related to some birth related problems. The most common cause of low back pain is the trauma. Then there are some inflammatory pathologies like the arthritis, rheumatoid arthritis, or degenerative arthritis. Then the spine consists of the anatomical structure, bone, ligament, muscle, tendons everywhere. So the focus of the pain can be everywhere. Then degenerative consists of the joint arthritis, just like in case of knee pain or elbow pain that has degenerative feature, same is the spine, which is about age related. Then neoplastic causes, generally in case of males, it comes from the metastatic secondaries from renal cell carcinoma, prostate carcinoma, or thyroid tumors. In case of females, it comes from breast. Then metabolic causes, generally we orthopedicians deal with some metabolic causes like calcium deficiency, phosphate deficiency, vitamin D deficiency, and other metabolic causes like hypothyroid, hyperthyroid,
হ্যাঁ
etc.
পরশু
Is there any problem?
নাহলে কালকেই যাবো আমরা রাত্রে
Is there any problem?
রাত্রে যেতে পারবো
Is there any problem? Is there any problem?
স্যার স্যার
Then there can be some sources of low back pain which are not related to the spine. Even in case of pancreatitis or chronic liver disease, the patient can have the features of low back pain. So every orthopedician should keep in mind the metabolic causes and the general causes from the abdomen. Then there are some miscellaneous causes like even anxiety, depression, or emotional distress, emotional stress can cause low back pain, that is called somatoform disorders. There are some spinal causes of low back, non-spinal causes of low back pain like visceral, as I have already discussed, from the abdominal viscera. Then piriformis syndrome. This is a muscle which transects the sciatic nerve. So whenever this is actually due to the anatomical variation in the sciatic nerve, then normally in 70% population, sciatic nerve pierces the piriformis muscle. But in some cases, like 30% patient, it either passes below the muscle or above the muscle. So because of anatomical variations, the patients have this sort of syndrome which resembles sciatica. Then bursitis, this may be due to, this is not so much important in case of low back pain, but it is more important in case of hip pain, because in generally greater trochanter bursitis may result in low back pain. Then fibromyalgia, this is chronic muscle fatigue syndrome. This generally occurs in the females in 20 to 40 years of age with, and this is always associated with some emotional problems. Then developmental dysplasia of hip may cause low back pain because of the deformity, pelvic obliquity. Then limb length discrepancy, normally 2 centimeter of limb length discrepancy in the lower limbs is acceptable. If there is more than 2 centimeter of limb length discrepancy, then this results in the altered biomechanics of the spine, which results in low back pain. Then posture. This is emerging problem in modern day society, generally in case of working population due to posture. Even low back patient, first thing that a clinician or a surgeon must point out the patient's posture while treating or seeing a patient of low back pain. Then obesity, this is also a growing problem, especially in case of females, that generally after pregnancy women gets obese and that results in low back pain. Then mood disorders, as I have already mentioned, that mood disorders, emotional distress or emotional stress, or any kind of financial problems results in mental problem, which results in somatoform disorder, which causes low back pain. So while treating a patient with low back pain, one must remember everything, that even a simple anxiety can cause a patient low back pain. Till now, clear? Any questions? Till now, any question?
No, sir.
We'll have the questions at the end of the session.
Okay, okay. Then, as a surgeon, we classify generally low back pain into four types. This is Fairbank and Hall's classification. Type 1 to type 4. Very simple to remember. Type 4 is unclassifiable low back pain, which is generally due to tumor infection and psychogenic. Then type 3 is neurogenic claudication. I will discuss in detail what is called neurogenic claudication. This is actually walking related pain and the patient is intolerant to walking straight. Then type 2 is chronic low back pain, which is mostly encountered by the physiotherapist. This is the most common variety which you will encounter in your practice. That is chronic low back pain. This is insidious onset. Pain may progress from mild to back, then pain will start from the back, then buttock, then thighs, then legs, and it depends on the severity. Then generally the patient responds to physiotherapy, and this is a thermometer pain. Just because of thermometer weight increases in intensity, there is increase in pain. Then type 1 is simple or non-specific low back pain. This is actually acute attack. There is no obvious reason. It spreads, it radiates till buttock, means above knee. It never goes below the knee. And it is always better with the activity. So treatment is never restriction of activity. So in treating a low back pain patient with acute low back pain, that is type 1, treatment is activity. So advice is generally given just for muscle, because there is muscle spasm. So rest is given for 2 to 3 days for muscle to get relaxed only. That's it. Then there are four types of low back pain: type 1 to type 4. Type 1 is acute, type 2 is chronic, type 3 is associated with neurogenic claudication, and type 4 is unclassifiable, which consists of infection, tumor, and psychogenic. Then, how to examine a patient? Whenever a patient with low back pain comes to your OPD, how you should assess? Start seeing the patient with when he or she opens the door. From the gait itself and the attitude, deformity, and the posture of the patient, you can diagnose a patient of low back pain that this patient has this disease. So always try to see the patient when he or she opens the door. Generally, due to we can see gait of the patient, then posture. This is a posture of scoliosis or acute low back pain. Then there are spinal related causes, like just I have already mentioned that there are spine consists of bones, ligament, tendon, muscles, then disc, etc. So problem can be anywhere. So generally arthritis, there are two arthritis. One is the disc related, one is the intervertebral disc arthritis. Second is the facet joint arthritis. Third is there is arthritis in the dorsal spine between the attachment joints of ribs and the transverse process of the vertebra. Then rheumatoid arthritis generally affects the cervical spine, not the low back. Then ankylosing spondylitis is an axial spondyloarthropathy which affects the whole of the spine, then sacroiliac joint, and this is a typical feature of bamboo spine appearance. Then osteomyelitis. Infection can occur anywhere. Most common site of infection in case of a spine is vertebral body. So whenever there is infection, it consists of two whenever there is infection, it can be acute or chronic. Then osteophytitis, this is generally degenerative. Then rupture disc, spondylolisthesis is the forward subluxation of vertebra over one another. There are two types of spondylolisthesis which you will encounter. One is L5, between L5 and S1, that is mainly developmental, and generally between L4 to L5, that is mainly degenerative. Then a spinal stenosis, this is related to the canal diameter. When diameter is less than 9, it is called a spinal stenosis. It is of two types, central canal and peripheral canal stenosis. Then a sprain or a strain, just like anywhere in the body, there can be muscle sprain, ligament sprain, whatever. Any structure, muscle related to musculoskeletal system can go into a sprain or a strain. These are the causes which we will deal with. Then, for seeing any patients with low back pain, first we have to rule out any red flag sign, means if there is any dangerous thing or not. This is a quite long list which you should ask for. Generally, less than 18 and more than 50 is a high risk sign. Then patient has a history of fever or any constitutional symptoms like fever, weight loss for many days. Then any significant trauma. Then is there any sign of cord compression like corticosteal syndrome, saddle anesthesia, bowel bladder abnormality, or any history of tumor? So any patient with red flag signs should be dealt seriously. Except from this, the other low back pain is due to normal sprain or a strain or muscle spasm, whatever. But red flag signs should never be missed out. And this has also some medical legal issues with these red flag signs. So in every prescription of low back pain, you should mention whether there is a history of any red flag signs or not. Not to write trauma, there is no history of trauma, there is no history of fever. Just write one word that there is no red flag sign. It means you have ruled out everything. Then there are some also yellow flag sign generally is due to psychological or behavioral factor, just like I have already said that some emotional stress or occupational, social, economic, etc. But clinical red flag sign, you must rule out everything. Then assessment of low back pain consists of the history taking. Pain has a mnemonic of Socrates: site, onset, character, radiating feature, then aggravating or relieving factor, any associated feature, then time, course, duration, exacerbating and relieving factor, and the severity. Severity should be assessed in visual analog scale, means from no pain to most severe pain. Okay. Then duration, site, and the onset of the feature, onset of the pain is very much important. Whether this is any acute onset, just like in case of trauma, or in sudden lifting a heavy weight. Then past history, any medical or surgical history. Then psychosocial, just because psychosocial results in low back pain. Then family history, because family issue can result in low back pain. Then general examination, just like examination of other systems, we should to do general physical examination is first, which consists of the higher functional status, then build, nutrition, everything has its importance. Build, nutrition, then pallor, clubbing, jaundice, cyanosis, edema, then vital signs. Just in one sentence, you must clear out that there is no abnormality in general physical examination. Then other system examination, especially abdominal examination, because low back pain, can be some sources of low back pain from the abdominal viscera. So if abdomen is normal, then you have ruled out everything from the low back pain, from the causes which has resulted low back pain from the abdominal. Then spine examination, as an orthopedician, we are dealt with the musculoskeletal system. So we are more concerned with our spine examination. Whenever a low back pain enters, the examination should start, and the examination should start from the gate. Generally, from the gate, you can see some gate patterns, like specific gate patterns like Trendelenburg gate, then high stepping gate, antalgic gate. A patient with low back pain is holding his back with his hand in case of acute disc prolapse. Then you should on there is one protocol: inspection, palpation, movement, measurements, then neurological examination, then joint above, joint below, and a special test. In inspection, you should look from the front, back, side. In inspection, we generally see the skin. Is there any signs of neurofibromatosis or not? There is some tuft of hair or any puckered scar which results in non-fusion of the L5. Generally, there is a gap between L5 spinous process, that is mylocyl, meningomylocyl, etc. That is spina bifida. Then attitude, generally the attitude of the patient should be noted. In case of acute low back pain, the patient is tilted to the normal side and holding his back with his hand. Then any deformity, generally the deformity is in three-dimensional plane, just like in case actually a scoliosis is a three-dimensional deformity, but generally from the back we see there is a S-shaped deformity. So in case of any S-shaped deformity, we should check down whether the deformity is correctable or not. Means it is coming from the spine or the hips. Just ask the patient to sit and bend forward. If deformity is correctable, then it is coming from the hip, not the spine. If the deformity is not correctable, then it is coming from the spine. Then any condition of a skin mark. Is there any healed scar, sinus, or etc., which signify tubercular post spine? Then palpation. In case of palpation, we generally see local temperature, it is raised or not. Then tenderness. There are two ways of eliciting the tenderness: direct and indirect. Direct is just palpating the spinous process. Second is the just rotating the spinous process. Then movement. Spinal movement consists of flexion, extension, lateral rotations. Everything should be documented. Then neurological examination, it consists of the higher functional status, then cranial nerve signs. Then generally we are more concerned in the spine with motor, sensory, and autonomic features. So in case of muscle, we see generally the tone, power, reflexes, etc. In case of sensory, we look for the sensory nerve distribution patterns. Generally, there is one simple method of examining the muscle. Generally, in case of the spine, we see what is the lesion and where is the lesion. That is the if you can find out these two things, then your diagnosis is almost 90% correct. So, in case of where is the lesion and what is the lesion, from history and general examination, you can make out that this is the problem. But in case of a spine, where is the lesion, that is more important. So that is assessed by the neurological examination. In case of motor feature, generally low back, we are concerned more with the low back. So it starts from L2 nerve root, L2, L3, L4, L5, S1, S2, 3, 4. So just ask the patient to sit and ask the patient to flex his hip. If he or she can flex her hip, then power is either 3 or more. Then just by gentle resistance ask the patient to flex. If he or she is flexing her hips, then it is quite normal. If it less than normal, then it is grade 4. If she cannot lift her hip, then the power is 2 or less. If there is only flickering movement, then power in the thigh, flexors of the thigh, then it is 1. If he or she cannot flex her hip, then power is 0. Same for the knee. Look for the quadriceps L3. Then L4 are the ankle dorsiflexor. L5 is the extensor hallucis longest power, or you can assess the power of gluteus medius L5. Then S1 are the plantar flexors, and S2, 3, 4 are the anal external sphincter muscle contractors. So just assess the power. If abnormality, whatever is the abnormality, you can assess where is the problem. Then do reflex testing like patellar jerk, clonus, ankle jerk, etc. You have to find out where is the lesion and what is the lesion. That's it. Then investigation. Generally, in case of low back pain, there is a standard protocol when to investigate, when you should go for investigation. In case of, there is some indications for investigation in low back pain just in case of trauma. Whenever the patient has significant trauma, then you should go for X-ray. Generally, X-ray is taken lumbosacral spine, anteroposterior and lateral view. When it is suspected that there is pars interarticularis fracture, then you should go for right and left oblique view, 45-degree oblique views. That is also called Ferguson's view. Then other indication of investigation, generally radiological investigation, is any inflammatory or infective disease which you have suspected in your history, whether the patient has any history of high grade fever, constitutional symptoms, etc., or any history of neoplastic disease, like a patient has long standing urinary problems like BPH or prostatic carcinoma or any thyroid tumor or renal cell carcinoma, you must examine the spine and go for the investigation. Then first investigation should be the radiological, then blood parameters should be assessed for metabolic diseases or whatever. This is
Sir,
actually
can you please once switch off and switch on the video again
switch
so
off
that the
and switch off and switch on. Okay, stop video. Start video. Now it is good.
yeah.
Okay. So pain assessment is done with universal pain assessment tool. This is very this is very difficult to remember. Actually, the pain is assessed on base of visual analog scale. 1 0 is the minimal pain when patient has never felt it, and 10 is the worst ever pain possible. So accordingly, this is actually a subjective tool which you should, this is very much not reliable, but this is generally done to assessment. Generally ask the patient, in if there was 100% before, what is the percentage now? Then he or she will tell, I am 50% okay. It means the visual analog scale is 5 or 6. This is very simple to remember, but assessment with universal pain assessment tool is very much difficult. It is very difficult to remember actually. Then general examination already discussed, motor assessment already discussed, testing of the muscle strength, reflex sensory, generally sensory patterns. Actually, it also signifies where is the lesion. Very simple to remember. Medial portion of the thigh consists of L2. Inguinal region L1. Medial side of thigh L2. L3 is the anterior surface of patella. Then L4 is the lateral portion of the leg. L5 is the dorsal Weber space. S1 is the medial side of foot. S2, 3, 4 is the anal region. So very simple to remember, just touching by pin or a piece of cotton, you can assess light touch, deep touch, then temperature, etc. And you can assess your level of lesion. Then there are some specific gait. Foot drop gait is high stepping gait. Even with the just with the gait pattern, you can assess that the patient has L4 nerve root compression or any injury. Then investigation, first investigation should be radiological, that is X-ray, and that is X-ray of LS spine, anteroposterior and lateral view. when you are suspecting any cord compromise, when to do MRI, that is very much important. Now in practice, in scenario that everyone is writing MRI, but this has a radiological hazard as well. Even in case of degenerative spine, you will see there is disc prolapse, whatever. Even is if a 35-year-old patient can do his or her MRI, he or she will notice that there are lots of features in MRI, but that is not significant and that is not symptomatic even. So there are some standard protocols when to advise MRI. When there are signs of cord compromise, when there is any deformity, when there are some specific features like foot drop, when there is nerve root compression, then you must order MRI. But in regular practice, you should never advise MRI. Many patients will come to you and he or she will ask that doctor please write MRI, because without doctor's advice MRI is never written, never done. And this is a medical legal litigation in USA, that whatever investigation you are writing, you are responsible. Patient is not responsible. Patient will ask you definitely that I want to get cured, that write MRI, write X-ray, write this blood investigation. But if you are writing, you are solely responsible, not the patient. Then CT scan is done whenever you are suspecting any bony abnormality like pars interarticular fracture or any significant trauma. Significant trauma signifies any road traffic accident, fall from height, or any major trauma, rollover, etc. Bone scan is indicated when you are suspecting some tumor or any infection like tuberculosis or acute homogeneous osteomyelitis, or any tumor like prostatic carcinoma, breast carcinoma, or renal cell carcinoma, lung carcinoma, etc., which metastasizes to the bone. Then some, this is a discussion about some specific disease which we encounter in case of our day-to-day life practice. Generally, just now I am summarizing in a gist. Patient coming to OPD with low back pain. First ask whether it is acute or chronic. Chronic means more than 6 weeks, acute less than 6 weeks. Then ask whether it is incidence or incidence means
Dr. Mishra has joined us. We're just waiting to get his audio video connections clear again.
where is the slide, Babu? Slide.
So you're audible, but volume
Ah,
is low, and
screen share.
kindly screen share.
Okay, okay. I am doing the screen share. Screen. Now it is it visible?
Yes, yes, it is visible.
So I have already dealt with the investigations, X-ray, MRI, CT scan, and the bone scan. What are the indications of these investigations? These are some specific low causes of low back pain we generally encounter in our day-to-day life practice. So whenever a patient with low back pain comes to our clinic, we just first classify it is case of whether it is acute, subacute, or chronic. Chronic generally goes to the physiotherapist. Acute one is the treatment is activity. Third is associated with neurogenic claudication. This is an example of type 3 lumbar canal stenosis, lumbar spinal stenosis. Whenever the diameter of the canal is less than 9, it is called lumbar spinal stenosis. It is of two types, central and peripheral. Generally, stenosis occurs due to the disc in the spinal space, in the root space. The clinical features generally most often there is associated low back pain, but the most dominant feature is the leg pain. That is neurogenic claudication. The patient have numbing, tingling sensation, or the weakness in the. There are three types of symptom: motor, sensory, and autonomic. Motor symptom consist of the weakness in the same pattern which the nerve is affected. If L4 nerve root is affected in case of a spinal stenosis, then there will be weakness of the ankle dorsiflexors. and there will be the sensory loss in the outer aspect of the leg. Whenever the L5 root is affected, there will be weakness in the plantar flexors and the gluteus medius. So there will be Trendelenburg gait and weakness in the plantar flexors. So depending on the which the nerve root is involved, the patient has a specific feature. Then what is the difference between neurogenic and vascular claudication? Claudication means the pain in the leg. That is called claudication. So there are some specific differences which you must notice. What is the difference between vascular and neurogenic claudication? Generally, in case of neurogenic claudication, first thing, wife is the main concern which you notices you at the time, good time, bad time. She will criticize you for everything. Whenever you are being criticized by your spouse, this is neurogenic claudication. Because whenever there is a stooping posture, bending forward posture, and the patient walks with stooping posture, then think it as neurogenic claudication. Patient will not complain of this. This is in the earliest stage of all. Wife or the attendant of the patient will tell the he or she is walking like this. This is the earliest feature that you should must point out that this may be a cause of neurologic claudication or the type 3 pain. Then the patient of neurogenic claudication has a variable walking distance and has no relation to the speed of walking. But in case of vascular claudication, it is associated with generally the speed of walking. More you walk, more will be the pain. But in case of neurogenic claudication, this is not dependent on the speed of walking. And in case of neurogenic claudication, the pain starts from above below. First, it will start in the back, then buttock, then thigh, then leg. But in case of vascular claudication, just reverse because that is due to ischemia. So it will always start distally. Generally, it is easier to walk uphill. Means the patient will complain of, in case of neurogenic claudication with low back pain, the patient will complain of pain on moving down stairs. Because in case of walking uphill, due to stooping posture of the patient can walk uphill. Is that till now clear? Am I audible?
Yes, sir, you are audible.
Then generally, in case of diagnosing a type 3 low back pain, you have to look for neurogenic claudication and you must differentiate it from vascular claudication because vascular claudication is a very much common cause of low back pain. Low back, actually leg pain, but that has a prominent feature with low back pain. When a patient with a low back pain, you must rule out vascular claudication because both can be similarly associated with it. So, whenever you are suspecting a vascular claudication, you must rule out DVT, deep venous thrombosis, or any primary pulmonary hypertension, or varicose veins, or insufficient veins. Then, this is the most common feature whenever patient comes, हमारा disc चला गया. This is the most common cause which one utter in day-to-day life practice. Every low back pain has no disc problem. You must rule out everything before in stamping a patient of low back pain with a PIVD. Generally, one thing in a recent RCT, it has been found that even a disc prolapse patient, there is no role of surgery. A patient with disc prolapse in which there is no canal compromise, a disc prolapse patient can be recover well to full activity in about 1 year. So never think of surgery in case of disc prolapse until the canal diameter is so much less, means below 8. Then a spondylolisthesis. A spondylolisthesis means forward slipping of a spine. Generally, one vertebra slips over other. Generally, this is traumatic, and there is fracture in the pars interarticularis. And the most common site of traumatic spondylolisthesis is L5 and S1 junction. So there will be break in the L5 pars interarticularis. But sometimes in case of degenerative arthritis of the spine, there is forward slippage of L4 vertebra over the other, over L5. That is, if whenever L4 subluxate anteriorly in case of low back pain, think it is a cause of degenerative, not the traumatic. Traumatic almost always occurs at L5 S1 junction because L S1 is fixed, sacrum is fixed to the pelvis, spine is movable. So whenever there is trauma, there will be pars interarticularis damage, and this is almost about in case of 60% patients. This should be operated. Never leave a pars interarticularis L5 fracture as such traumatic one because it will displace anteriorly more in case of in future, and that will result in cord compromise or cauda syndrome. This is Meyer's grading. Whenever there is less than 25% slippage of the vertebra, that is grade 1. Grade 2 is 25 to 50%. Grade 3 is 50 to 75%. And grade 4 is more than 74.5%. And there is one other grade that is called a spondylolosis. It means there is for one vertebra is looping down anteriorly over, means there is no contact of the vertebra. Then a spondylolosis. Actually everyone, तुम्हारा cervical spondylosis हुआ है, lumbar spondylosis हुआ है, and this is the most irritating word in clinical practice. Everyone, every patient with low back pain must have a spondylosis because this is a degenerative feature of the spine which will occur. You cannot prevent it. Generally look for other causes of low back pain. Last stamp it as spondylosis. Before a spondylosis, there are innumerable diagnoses. So this is generally a diagnosis of exclusion. Then dysfunction in sacroiliac joint can sometimes cause low back pain and leg pain. Leg pain from the sacroiliac joint dysfunctions can be particularly difficult to differentiate from radiating leg pain caused by lumbar disc herniation sciatica, as they can feel quite similar. Because sciatic nerve, in case of lumbar disc herniation, this is the nerve root that comes. The lumbar disc herniation generally consists of L2, L3, L4, L5. Generally, most common is L3 to L5, and sciatic nerve root value is L2 to LS1. So, whether there is lumbar disc herniation or sacroiliac joint dysfunction, the nerve root, because the nerve roots are same, so both the symptoms will appear quite similar. Then piriformis syndrome, already I have discussed that the muscle sciatic nerve, due to peculiar anatomical course of the sciatic nerve, in case of more than 70% patient, sciatic nerve pierces the piriformis muscle. Whenever there is any edema of the muscle because of trauma or neoplasm or any inflammation or generally due to bursitis, there will be irritation of sciatic nerve. Whenever nerve is irritated, it causes its features like pain, numbness, tingling along its distribution. That's it. Then ankylosing spondylitis. This is a typical patient with ankylosing spondylitis. This is a axial spondyloarthropathy. It starts with the sacroiliac joint, sacroiliitis, then comes to the lower back, then mid back, then upper back, then cervical spine. Even it and results in bamboo spine appearance. And generally this occurs in case starts in early age, like in early 20s. If a low back pain patient with low back pain with morning stiffness comes to you in early 20, 30, 40, you must rule out ankylosing spondylitis. This is a genetic condition related to HLA genes number 6. So you should look for HLA-B27 gene. Then management. Everything is diagnosed now, then we are concerned not only diagnosing the problem but curing the problem is beneficial to the patient and beneficial to the surgeon also. So management consists of generally investigation. We have already investigated the case to arrive at a diagnosis. Generally, investigations are done for three purposes. Number one, for confirmation of diagnosis. Then number two, for planning of the case, how will I manage, whether operative or conservative. Then for some investigations are for the prognosis, just like in case of prostatic carcinoma metastasizing to the spine. For prognosis, we do PET scan. What is the whether wherever the cancer has metastasized, or HRCT thorax, high resolution CT scan of the thorax, whether the patient has any metastasis to the lungs. So investigations are done from three purposes: one for confirmation of diagnosis, number two planning, treatment planning, whether operative or conservative. Then other investigations are for prognosis of the case. Then some general principles of low back pain. Generally, I am just from my clinical practice, I am just summarizing one thing. Whenever a patient is coming to you, from the age you can arrive at a common diagnosis. Whether it is less than 18 or less than 20, think number one, if a patient of below 20 coming to you, always rule out some metabolic causes like rickets, osteomalacia, any congenital or infection. Between 20 to 40, rule out inflammatory pathologies first, ankylosing spondylitis, rheumatoid arthritis, or any infection. And in the whenever you are not finding anything, look for degenerative, that is lumbar spondylosis, and psychogeny. If a patient of more than 40 coming to you, first degenerative, then metastatic, then infective. Look for the causes, assess properly, investigate the case, then formulate the plan. This is the general principle of treatment. Then pharmacology, generally rest is given for 2 to 3 days in case of acute low back pain. Then some analgesic is given, muscle relaxant. According to generally treatment of low back pain is generally symptomatic. Then non-pharmacological, like in case of low back pain degenerative, patient is advised not to sit prolonged or do work, postural care, avoid forward bending, lifting heavy weight, depending on the situation. Then third is pharmacology, analgesic, then morphine. Any analgesic can be used, but analgesic should be used as per the general condition of the patient and medical comorbidities. Generally, drug of choice should be paracetamol. Then other drugs can be used like COX-2 inhibitor, etoricoxib, etc. Then muscle relaxant. Whenever you are suspecting a muscle sprain or a strain, you must prescribe muscle relaxant. Muscle relaxant are of different categories, whether sedative, non-sedative, centrally acting, peripheral acting, etc. So, use of muscle relaxant should be judiciously. Else, there will be diaphragm paralysis and patient may succumb due to respiratory paralysis. Then rehabilitation, because this is rehabilitation is more important in case of type 2 low back pain, which is of chronic variety. Because in case of whenever it is a general rule, whenever there is pain, muscle goes into a spasm and the muscle becomes weak. So rehabilitation part is more important in case of type 2 or any other operative, which is done by the physiotherapist only and should be done by the physiotherapist. Whenever a patient of low back pain, physiotherapy must advise is a must for just for the rehabilitation. It is not mandatory that you should use the instruments. Even simple exercises can help. Then at last, we surgeons are concerned with the operations only. So we are always ready with the blades. So when to operate? Before when to operate, it is more important when not to operate. Generally, classify accordingly. In case of type 1, type 2, never operate. Type 3, type 4, operate with proper indications. When not to operate is more important than when to operate. So just holding a scalpel in the hand does not signify that we should operate every case of low back pain, because 90% of the cases of low back pain are treated conservatively. There are some specific indication when to operate the cases of low back pain. Some indications of surgery are failure of conservative management. That is number one. But it doesn't mean that you have given medicine for 6 weeks and the patient has not responded, you will do surgery. The failure of conservative management should be proper. Conservative management should be done by the physician proper and should be taken by the taken by the patient properly. So number one is the failure of conservative management. Number two, leg pain is more than low back pain. It means type 3 features. Neurogenic claudication is present, and that is so disabling to the patient that he or she cannot walk. Then in case of lumbar canal stenosis, the canal diameter less than 8, you should go for operation. Or some neurovascular compromise, like in case of foot drop, it must be operated. Then the most emergency feature of low back pain is cauda equina syndrome. Cauda equina syndrome is a surgical emergency in case of low back pain, and it should be and must be operated. It never should. And every physiotherapist or the surgeon, concerned surgeon, orthopedic or the neurosurgeon must diagnose a case of cauda equina syndrome and cannot leave it. And it is a surgical emergency. It should be operated even on the day one. Cauda equina syndrome should not be left behind. So the features of cauda equina syndrome are, there will be saddle anesthesia, means around the anus there will be anesthesia, bowel and bladder disturbances, and the weakness in the plantar flexors or the glutei, means S2, S3, S4 involvement. Then rehabilitative part. The most common type of low back pain is type 2, that is chronic low back pain. So as I have already told, that rehabilitation should be done, and it must be done and should be done under proper supervision from the physiotherapist, by the physiotherapist, because pain causes the weakness of the muscle generally due to disuse. Number one, due to disuse. Then whenever there is pain, there will be the release of inflammatory mediators, then results in the inflammations of the muscle, and it causes the flabiness of the muscle. The strength of the muscle is lost and the flexibility is lost due to fibrosis. Whenever there is pain, there is inflammation, so there will be fibrosis, so the flexibility of the muscle is lost. So exercises, then weight control. As the weight gain is getting more and more, so weight should be controlled. Then behavioral relaxation techniques. This is due to combat the mood. So there is one new feature, one new exercise is coming for it, that is progressive muscle relaxation exercises, PMR exercises. That has a tremendous feature in case of controlling the anxiety plus low back pain. Then alternative medicine and psychiatric modalities like cognitive behavior therapy. Depending on the cause, treatment should be formulated. There is no fixed protocol for the management of low back pain, but this is it. But this depends on individual basis, and it should be done judiciously by the concerned surgeon. Then how to prevent it? Avoid forward bending activity, avoid heavy weightlifting activity, avoid long standing activity, control the body weight, wear low heeled shoes, avoid smoking. Actually, smoking has a toxic substance, that nicotine, which causes the bone weakness, which results in metabolic low back pain. Then smoking causes degeneration of the disc, facet joint arthritis, and it causes, as a whole, causes the lumbar spondylosis. Then nutritious diet should be taken so that metabolic bone disease cannot occur. Then these are some exercises which done by physiotherapists, generally spine extension exercises and back strengthening exercises are advanced. And in what ways this should be done? This must be done under the supervision of physiotherapist only. Then surgery. When to do? I have already discussed it. When to do, but when not to do is more important than when to do. First is the surgical emergency, which should never be missed, is the cauda equina syndrome, progressive neurological weakness, or any failure of conservative management, involvement of one peculiar nerve root like foot drop, patient with foot drop, etc. Then surgery, it is it can be dealt in details, but I don't think that this should be done here. Thank you. Any question? Any questions?
Hello?
Hello? Any questions?
Hello?
Yeah, it's over now.
Hello? Uh, Hello?
Hello, it's now. It's now over. Just
Okay,
recheck
sir.
it. Same,
Sir?
same. Any questions now?
Yes, sir.
Yeah, fine.
Hello?
Hello. Any questions? Am
Hello?
I
Yes, sir.
audible?
Hello? Yeah, you
Hello.
are audible.
Yeah. Any questions now? Slide is complete now.
In spinal canal stenosis cases, uh, hello?
Yeah.
Yeah, in spinal canal stenosis cases, let's see, we treat the patients with physiotherapy management conservatively.
Yeah.
So, after 6 7 months, they are coming again and they are telling the radiculopathy pain, which is worsening at night time only. And stiffness is also increasing at night time. So, with this tense modality and with this exercises, which increases the flexibility of the spine, the patients gets better, but daytime, but nighttime the patients are always every day complaining of this pain increasing and stiffness increasing. So
Yeah.
in that case, what management we can go?
Actually, actually in cases of lumbar canal stenosis, whenever you actually in case of night, the muscle goes into relaxation because in daytime, in case of day, the muscle is in a spasm, so it mobilizes the spine. But in case of night, when the patient is sleeping, muscle goes into relaxation. That is a normal phenomenon. So whenever the muscle goes into relaxation, there is more chance of disc protrusion. Whichever the actually whenever there is pain, the muscle goes into a spasm and it keeps the spine somewhat fixed. So whenever the muscle goes into relaxation, there will be pain, but it will be not be so much disabling for it. You can go for physiotherapy again.
Yes, but they should use this lumbar sacral belt.
No,
Will it
there is
help?
actually this is actually has a placebo effect only. Lumbosacral belt.
Yeah, we know that, but during night time they can't turn and on the bed
Actually,
also.
for actually there should be muscle relaxant and there are many drugs which can combat this. The pregabalin, gabapentin, this should be dose dependent according to the body weight and the symptomatic features. Actually, the every low back pain patient is somewhat different. You should treat it on day-to-day basis. According to the patient, you must do treatment. There is no fixed protocol for it. There are some principles of treatment of low back pain. what is the problem, where is the problem, and how should you treat. This is there is some basic problem, but there is no recommended protocol that this you should use.
Thank you, sir.
Okay. Actually, the question should be such that you have encountered in your day-to-day life practice. Okay. Whatever problem you have faced in your practice, you must ask it. Any more? Any other question from the panelist or audience?
Sir, from my audience, there is a question
Yeah.
that they want an elaboration on the difference between spondylosis and spondylitis.
See, this is a simple definition. Wherever there is itis, it means there is inflammation. A spondylitis can be of various causes, from inflammation to infection. But a spondylosis is a degenerative feature of the spine. That there will be osteophytes, there will be syndesmophytes, there will be facet joint arthritis. Actually, all the degenerative features will be there in a spondylosis. But in case of whenever there is itis, there will be inflammation. That is the simple difference, basic difference. Wherever in every word, if there is itis in the last, it means inflammation, and that is due to inflammatory feature. Any inflammatory pathology like ankylosing spondylitis, rheumatoid arthritis, or any infections like tubercular, acute homogeneous osteomyelitis, etc. Am I clear?
Okay, sir.
Any doubt? Actually, you must ask from your day-to-day life practice what problem you have encountered in treating a low back pain. Because there is no one who can treat every low back pain. Everyone must have encountered such.
Uh, so, good evening, sir. Hello, am I audible?
Yeah.
Sir, I'm Sonali. I wanted to ask you one question. Like, when there's a listhesis in the lower lumbar region, right?
Yeah.
F5
At
L4
which level? At which level?
region, sir. Suppose if it's a posterior listhesis or an anterior listhesis, in which case extension exercise, like many doctors, I'm sorry to say, like they tell both type of exercise can be done in listhesis. Most like I've faced this once or twice, you know. So posterior listhesis, can we do extension exercises?
Actually, in case of listhesis, only core muscle strengthening exercise is sufficient.
Okay,
Nothing else.
only core muscles, right?
Yeah.
So no.
Only back strengthening muscle is sufficient.
Okay.
But what is the pathology, that is more important. Whether listhesis is due to pars interarticularis fracture, if you are exercising spine extension or flexion exercises, then it may displace,
Right.
because that is a fracture. Actually, pars interarticularis fracture is a dangerous thing.
तो उस केस में सर हमको पहले इमोबिलाइज करके रखना पड़ेगा
नहीं,
ना?
इमोबिलाइज नहीं करना है, पहले डायग्नोज करना है
ये
कि वो क्यों हुआ है. So for that there is Ferguson's view, right and left 45-degree oblique view.
हाँ.
Whenever there is a history of significant trauma, you should go for right and left 45-degree oblique view, and there will be a Scotty beheaded, a Scotty dog sign. Okay, there is a peculiar sign that is called beheaded, a Scotty dog sign.
Yes, sir. Right, sir. Okay. Thank you, sir. Thank you.
Um, Sir, one more question I want to ask you. Sir, I have a patient that he has a history of a spondylolisthesis, L5 over S1. It's an anterior listhesis, grade 3. So, but he has a symptom of like since long he got his listhesis more maybe before the just s- 5 years back, but the symptoms what he has started it's long 15 years back. The symptoms are the same, like he has a cramping and a stiffness pain on his all over his right side of the body, like he feels like
Moreover,
all the organs are shifting towards the right side. So what can we rule out?
generally this is a developmental spondylolisthesis. Okay, so you
Pardon, sir?
must. This is a developmental spondylolisthesis. It is present
Okay.
in birth, but it manifests in the adulthood. Means after 20-25 this like age. Okay, so you must rule out any history of trauma first. Then the
No, he didn't have actually.
then this is a cause of developmental spondylolisthesis. There are many causes of a spondylolisthesis. Most common cause is traumatic. So you, whenever you are doing a Ferguson's wheel, you will see there will be the break in the pars interarticularis, and this will be a atrophic variety. That is, I am focusing that whenever a patient of spondylolisthesis, rule out the causes. What can be the cause? Whether it is developmental, congenital, developmental, neoplastic, or traumatic, or due to any other causes. So this must be ruled out. What is the cause, there will be treatment. Because in case of low back pain, there is no fixed protocol. What could be done? This is
Okay,
just
but
generally
sir, sorry to
and
interrupt you.
yeah,
But sir, he never complains of pain. It's just he
that
complains
is
that he
fixed.
feels it's shifting of the all the organs and muscles towards the right side, and it's
That
not
is
only
due
limited
to
to his lower back. It's
yeah.
he always complains of his chest muscle as well as his neck muscles as well. So is he related? Is it related to the spondylolisthesis or is something
Yeah, it
else?
can be a spondylolisthesis. It can be due to, but you must rule out whenever a patient is complaining like systemic symptoms, then you must go for the systemic examination first. But it can be due to spondylolisthesis because to combat the pain, the patient is moving his spine to the normal side, means your to the left side in this case, and due to that, the all the organs are moving. Whenever a patient is bending laterally, there is a scoliosis.
Yeah.
So the organs are moving to that side. But whenever he is saying that all the organs are being shifted to the right side, then you must go for examination of chest, abdomen, etc. But it can be due to a spondylolisthesis because of a scoliosis, because scoliosis is a three-dimensional deformity, not a two-dimensional deformity. There is one rotational component also. In sagittal, coronal, and rotational axis, there is deformity. So, due to that deformity, because of a spondylolisthesis, that is developmental. So, there can be any other associated syndrome also in this patient, like esophageal hiatus hernia, like this also.
Okay.
So, you must go for systemic examination, body as a whole, examination of the body. Start from the chest, abdomen, etc. And do X-ray of the whole spine. You will definitely find there will be a scoliosis.
Yeah, he has scoliosis developed.
That is
The
due to that
developmental
feature.
one.
That is due to that feature. He is complaining that actually the patient complains vague symptoms in case of low back pain. As a
Hmm.
doctor, you have to rule out what is the pathology, where is the pathology. In case of a spine, this is the only two questions which you should ask yourself. What is the pathology and where is the pathology? Okay.
Okay.
This is the developmental type of a spondylolisthesis L5S1. So the patient is complaining of all these type of things. So any syndrome should be also ruled out. Like it can be associated with bacterial syndrome. cerebral anomalies and anorectal anomalies, esophageal hiatus hernia, etc. There are a lot of things. Okay, am I clear?
Okay, sir. Thank you so much.
Yeah. Any questions? Any questions from anybody? No questions, sir.
No questions.
Thank you for your valuable
Only five,
time.
only 5 questions in this 1 hour lecture.
Maybe we
Means
don't know.
no
We'll be
means
there.
no one has treated the low back pain, and either no one has treated the low back pain or everyone has treated the low back pain 100% successfully. So in case of prescriptions, you must write a diagnosis. What is the feature? What is the disease?
Yeah.
Okay, so that the next clinician or the surgeon should encounter that this was the problem, for this the treatment has been done. Just not low back pain, for this physiotherapy, everything, exercises. Generally all the low back pains are not low back pains due to these pathologies. Okay, then I will share my two clinical experiences. Okay, that is the most bitter ones also and the most dangerous one also. Okay, then I will sum up. One patient, I am starting now. Case number one. A patient from home at Howrah came to me with low back pain. The patient was mentally retarded, and the patient has a history of low back pain for about 1 year. 1 year. And because of low back pain, first consulted. Actually, no one goes to the home, and that is due to the COVID effect. No one was going, so they consulted one physiotherapist. He went, gave some medicine, then physiotherapy, etc. But low back pain never subsided. Then he consulted general physicians, low back pain, same treatment, analgesic, muscle relaxant, then sedative, anxiolytic, pregabalin, gabapentin, everything was tried. But the patient was not cured. Ultimately, the patient consulted to me at my chamber. I just see the patient, then from just general physical examination, you can come to a diagnosis that this patient can have tuberculosis. The patient has severe pallor and about loss of 10 to 12 kgs of weight in last 6 months, 6 to 8 months. And the patient has constitutional symptoms of night sweats. There was no history of fever, but the patient has a complaint of night sweats only. Loss of weight, loss of appetite. When I examined the patient, there was severe pallor, and the and there was Kipper's deformity of the spine. Kipper's deformity of the spine means 2 to 3 vertebra was involved, and there was kyphosis, spasm, paravertebral muscle spasm. There was no cord compromise. I suggested the owner of the home that this can be a case of devious spine, but as the patient was mentally retarded, no one was willing to do MRI. For diagnosis of the devious spine, we generally go for contrast enhanced MRI. But as the patient was mentally retarded, so MRI could not be done. So there were almost about 3 months delay in the MRI. Finally, the MRI can be done at Narayana Hospital, and the patient came to me again, and it shows the features of devious spine. The same patient, if the physician or the physiotherapist or the clinician which has encountered the patient on the first visit, who have encountered the red flag signs, must have diagnosed the TB. So the patient was of a Pott's spine, tubercular spine, was left undiagnosed, untreated for 1.5 years. After the start of anti-tubercular drugs, the patient became well after 3 months, and he is now moving himself, doing his day-to-day life activities. So this is the importance of low back pain with red flag sign. This is the importance of red flag sign actually. Am I clear? Am I clear?
Yes, sir. You are.
Case number 2. A old patient about 60 to 65 years old age. Then, just like everything, low back pain, analgesic, anti-inflammatory, muscle relaxant, calcium, vitamin D, everything was used. But his low back pain was not relieved. Everyone said, अभी उम्र हो चुका है, अब जैसे चल रहा है उतना दिन ही चलाओ, तुम्हारा जैसे बाल पक गया है वैसे स्पाइन भी पक गया है. That's it. That was the dialogue. But the patient has a history of urinary incontinence, urinary retention, which no one has asked actually. So that was a case of prostatic carcinoma which has metastasized to the spine, and that was the cause of low back pain. So diagnosis of low back pain, etiological diagnosis is more important than symptomatic treatment. And for low back pain, not only analgesics, all analgesics are given. Analgesic, calcium and vitamin D. You have to reach a diagnosis, what is the etiology, and treat accordingly. These are the two cases which in recent last 6 to 7 months I have encountered and found it very difficult to diagnose, and that I have shared with you. Any more questions? Any more
No,
questions?
sir.
No, sir.
So should we stop?
Thank you for sharing your experience with us, sir.
Any more questions?
Hello.
Hello. Should we stop?
There is no question.
Okay.
Sir, one more
All
question
will-
is there in the chat box. It's someone asked, is Surya Namaskar advisable for postural backaches?
Yeah, definitely. That is actually McKenzie exercises. Surya Namaskar is actually in mythology, everything is been prescribed, but they have not written what is the cause and why we are saying so. Surya Namaskar is nothing but a spine extension exercise actually. You perform and you will find that this is a type of core muscle extension exercise and a spine extension exercise only. Okay, clear? Clear? Hello? Any more? Any more questions? Am I
Any more
audible?
questions?
Okay.
Yes, sir, you are audible.
Now it's over.
Uh, Tanushree, is there any question?
No, I don't think so. It's no more questions.
Should
We
we
can.
stop?
Yeah, thank you so much, sir, for your valuable time and your varied experiences sharing. We are honored to have you with us, sir. Thank you so much.
Thank you so much, Dr. N Mishra, sir, for your informative session. And thank you, West Bengal IP Women's Cell, for bringing this webinar. And on behalf of IP Digital Media team, I also thankful to all the viewers for being there with us. Thank you and good night.